Okay, our first condition for this deep dive is tabes dorsalis.
Right. And according to our sources, the mechanism for tabes dorsalis is degeneration demyelination of dorsal columns and roots by T. pallidum, 3 degrees syphilis, progressive sensory ataxia, impaired proprioception, poor coordination.
Okay, degeneration, demyelination. That mechanism really comes to life with a story we received from a listener. It's a grandson reflecting on his grandfather's experience. He wrote, I remember my grandfather, a quiet man, always seemed a bit off balance. He'd stumble sometimes, especially in the dark.
In the dark.
And said his legs felt like they weren't fully there. Like walking on pillows, he'd say.
Wow, walking on pillows, that's descriptive.
Yeah. He also complained of these sudden, sharp shooting pains that would just flash through his legs, seemingly out of nowhere.
Those lightning pains, clap.
We saw doctors for years, and they all just called it old age. But then one doctor noticed his pupils didn't react right to light, only when he focused on something up close. That was the clue.
Ah, the Argyll-Robertson pupil.
Exactly. It turned out to be tabes dorsalis, a late complication of syphilis he must have had decades ago without knowing. It was a shock, but at least we finally had a name for his wobbly gait and those strange, fleeting pains. So that image of walking on pillows and the wobbly gait, what exactly is happening in the nervous system that causes that profound lack of balance and those sharp pains?
Well, that's the progressive sensory ataxia he experienced. It stems directly from impaired proprioception, which is your sense of where your body parts are in space. What's really going on is that degeneration and demyelination of the dorsal columns and roots, those pathways are crucial for carrying sensory info, touch, vibration, and proprioception. When Treponema pallidum, that's the syphilis bacterium, damages them, that sense is lost. That leads to the poor coordination, the ataxia.
Right, the wobbliness.
And those shooting pains, they're a classic sign, often called lightning pains, just like the listener described.
And the grandfather's pupils not reacting to light, but only to near focus. That was the key diagnostic clue, right? What was that called again? And were there other physical signs doctors look for?
Absolutely. That specific finding is the Argyll-Robertson pupil. It's a classic, very high-yield association, almost pathognomonic, really. Other key things clinicians look for are absent deep tendon reflexes, the DTRs, and a positive Romberg sign.
A Romberg sign.
Yeah, that's where a patient stands with feet together and closes their eyes. If they sway or fall, it confirms that proprioceptive loss because they can't use vision to compensate anymore. Diagnosis is mainly clinical, but it's typically confirmed by serologic tests like the FTA-ABS.
And treatment.
Management involves antibiotics, usually penicillin, to stop the disease from progressing further.
Okay, shifting gears now, let's consider a condition with a very different impact on mobility. Poliomyelitis.
Right, polio. The mechanism for poliomyelitis, according to our sources, is poliovirus infection spreads from lymphoid tissue of oropharynx to small intestine and then to CNS via bloodstream, a destruction of cells in anterior horn of spinal cord, lower motor neuron death.
Destruction of anterior horn cells. This next story is quite poignant looking back in time. It was shared by a grandmother about her brother, little Tommy, from the 1940s. She shared, "My grandmother always told us stories about her brother, little Tommy, who got sick back in the 40s. It started like a bad flu, but then he just couldn't move his legs.
Oh, wow.
They just went limp, like cooked spaghetti," she'd say, her voice still tinged with sorrow. The doctors called it polio.
Cooked spaghetti. That's a striking image of flaccid paralysis.
He never walked again. His legs withered, a constant reminder of the unseen enemy that attacked his young body. It was a terrifying time before the vaccine, seeing children suddenly lose the ability to move, forever changed by a virus. That image, limp, like cooked spaghetti, it really sticks with you. How exactly does the poliovirus cause that sudden, dramatic paralysis, and what type is it?
Tommy's story is just heartbreaking, and it really shows the power of this virus. The poliovirus specifically targets and destroys cells in the anterior horn of the spinal cord. These are the lower motor neurons, the ones sending signals directly to the muscles.
Okay.
When those cells die, the muscle gets no signal. That causes what we call acute onset flaccid paralysis, exactly that limp feeling Tommy had. It's a classic lower motor neuron disorder, and it's often asymmetric, meaning one side might be affected more than the other.
So it's not just weakness, it's a total loss of muscle tone. Given the history here, what's the biggest takeaway for us today?
Precisely, a complete lack of tone and movement. The biggest takeaway, and what Tommy's story really hammers home, is the absolute critical importance of vaccination. Before the vaccine, this was a terrifyingly common reality. Now, thanks to widespread vaccination, it's largely preventable in most of the world.
Thank goodness for that.
Absolutely. Diagnosis back then was mainly clinical, maybe confirmed by finding the virus in stool or CSF. Management was, and still is if it occurs, supportive, focusing on things like respiratory support if needed, physical therapy, and rehabilitation.
Got it. Now let's try to make sense of a more complex genetic condition. Friedreich ataxia.
Okay, Friedreich ataxia. Our source describes the mechanism as trinucleotide repeat disorder, GAA, on chromosome 9 in gene that encodes frataxin, iron-binding protein, impairment in mitochondrial function, a degeneration of lateral corticospinal tract, spinocerebellar tract, dorsal columns, and dorsal root ganglia.
Wow, that's a cascade. This next submission is from a parent sharing a really powerful story about their daughter, Sarah. She shared, "My daughter, Sarah, started stumbling more than other kids around age 7. At first, we thought she was just clumsy, but it got worse.
Early onset.
Her walk became a wide-based, unsteady sway, like a drunken sailor," as one doctor described it.
The cerebellar ataxia.
Her feet started to develop these high arches, and her spine began to curve. The hardest part was the heart problem they found, hypertrophic cardiomyopathy.
Oh, the cardiac involvement is significant.
It was heartbreaking to learn it was Friedreich ataxia, a genetic condition that was slowly taking away her coordination and affecting her heart. Every day is a challenge, but we focus on managing her symptoms and cherishing her strength. So Sarah's story of stumbling and that drunken sailor walk, what's the medical term for that unsteadiness? And are those physical changes like the high arches and curved spine typical?
Yeah, that drunken sailor gait is a really classic description of progressive cerebellar ataxia. It often starts in childhood, just like Sarah's did. The unsteadiness comes from the degeneration of pathways like the spinocerebellar tract, which is vital for coordinating movements. And yes, unfortunately, those skeletal deformities, pes cavus, the high arches, and kyphoscoliosis, the curved spine, are very common features of Friedreich ataxia.
So it's not just the nervous system then. The parent mentioned a serious heart problem and also diabetes risk. How does a genetic defect related to an iron-binding protein cause such widespread issues?
It's really quite something. That single genetic defect, the GAA trinucleotide repeat on chromosome 9, causes a deficiency in a protein called frataxin. Frataxin is critical for mitochondrial function. Mitochondria are the powerhouses of our cells, right? So when they don't work properly, it hits high-energy organs the hardest, like the heart, leading to hypertrophic cardiomyopathy, and the pancreas, which increases the risk of diabetes mellitus. It's also an autosomal recessive disorder. That means a child needs to inherit a mutated copy of the gene from both parents.
I see.
Diagnosis is confirmed by genetic testing, looking for that specific GAA repeat expansion. And management is really supportive physical therapy, managing the cardiac issues, the diabetes, and so on.
Okay. Our next deep dive takes us into the realm of hearing, starting with noise-induced hearing loss.
Right. The mechanism for noise-induced hearing loss is described as damage to stereociliated cells in organ of Corti loss of high-frequency hearing first. Sudden, extremely loud noises can lead to tympanic membrane rupture, hearing loss.
Damage to those tiny cells. This story from a listener about their father is probably incredibly common. He shared, "My dad worked in a factory for 30 years, surrounded by the constant roar of machinery. He always joked about how he could tune out the noise.
No.
But then he started asking us to repeat ourselves, especially when the TV was on or we were at a family gathering. We noticed he'd miss parts of conversations."
Classic signs. Difficulty in background noise.
When he finally went for a hearing test, they told him he had noise-induced hearing loss, mostly in the higher pitches. The doctor explained how the tiny hair cells in his ears had been gradually destroyed by years of unprotected exposure.
Yeah, those stereociliated cells.
He regrets not wearing ear protection from the start, saying, "You don't realize what you've lost until it's too late to get it back."
That's powerful, and unfortunately, very true.
So what exactly are these tiny hair cells the doctor mentioned, and why is it usually the high-frequency hearing that goes first?
Those tiny hair cells are the stereociliated cells. They're incredibly delicate structures in the organ of Corti, inside the cochlea, our inner ear. Their job is to convert sound vibrations into electrical signals the brain understands as sound. Now, the cells responsible for detecting high frequencies, they happen to be located at the base of the cochlea, the part closest to where sound enters the inner ear.
Okay.
And they seem to be more vulnerable to damage from loud noise exposure over time. So losing those high pitches first is often the initial sign.
And the father's regret. That really highlights a crucial point here, doesn't it?
It absolutely does. The biggest takeaway from this story, and from noise-induced hearing loss in general, is prevention. Counseling people, especially those in noisy environments, about wearing hearing protection is paramount. Because while hearing aids can certainly help manage the loss,
Right.
once those delicate hair cells are damaged or destroyed, the hearing loss is typically permanent. You can't get them back. We should also remember that subtle, extremely loud noises like an explosion can cause acute damage, sometimes even rupturing the eardrum, the tympanic membrane, leading to sudden hearing loss. That might need surgery.
Very important point on prevention. Moving from that, let's consider presbycusis, another very common cause of hearing loss.
Yes, presbycusis. The mechanism, as per our source, is destruction of hair cells at the cochlear base, preserved low-frequency hearing at apex. A, aging-related progressive bilateral symmetric sensorineural hearing loss, often of higher frequencies.
So, destruction of hair cells again, but aging-related this time. This next story, from a grandchild about their grandmother, feels very relatable, they wrote. My grandmother, bless her heart, would always turn the TV volume up to levels that made the windows rattle.
Hey, yeah, we've all been there.
She'd often say, "Speak up, dearie, I can't quite catch what you're saying," or accuse us of mumbling.
Difficulty with speech clarity.
She could hear the dog bark, but struggled with certain voices or the higher notes in music. When we finally convinced her to get her hearing checked, the audiologist gently explained it was presbycusis, just natural aging of the ear.
The natural aging process.
It wasn't that she couldn't hear at all, but the higher-pitched sounds and distinguishing words and background noise became increasingly difficult. The hearing aids helped, but it was a quiet acknowledgement of time passing. So the grandmother could hear the dog bark lower frequency, but struggled with voices or high notes. This sounds similar to the high-frequency loss we just discussed. What really differentiates presbycusis from noise-induced hearing loss?
That's a really excellent question, and it's a key distinction to make. While both often involve that high-frequency loss first, presbycusis is specifically an age-related process. It's typically progressive, meaning it gets worse over time, and it's bilateral and symmetric, affecting both ears fairly equally. Think of it as the natural wear and tear of the auditory system as we age.
Whereas noise-induced has that clear external cause.
Exactly. The underlying mechanism, the destruction of hair cells at the cochlear base, can be similar, but with presbycusis, it's generally a slower, more gradual age of the process rather than damage from a specific external factor like noise. Her ability to hear the dog bark but struggle with higher-pitched speech consonants, that pattern is very typical.
So it's really the why, the cause, and the pattern of progression that sets them apart. How is presbycusis typically diagnosed then?
It's diagnosed primarily through pure tone audiometry, a hearing test. This will show those increased thresholds, meaning sounds need to be louder to be heard, especially at the higher frequencies. Other tests, like the Rinn-Weber tuning fork tests, help confirm it's a sensorineural loss, inner ear or nerve-related, rather than conductive, middle or outer ear problem.
And management.
Management is mainly focused on amplification with hearing aids. And as the story suggests, they can make a really significant difference in communication and quality of life.
Okay, now let's unpack a condition that involves an abnormal growth within the ear. Cholesteatoma.
Right, cholesteatoma. The mechanism here is described as abnormal growth of keratinized squamous epithelium in middle ear, 1 degree acquired from tympanic membrane retraction pocket, 2 degrees from tympanic membrane perforation.
So skin cells growing where they shouldn't be. We have a clinician's perspective on this one, remembering a patient named Mark they shared. For years, Mark had a persistent foul-smelling discharge from his right ear.
Otorrhea, okay.
And his hearing in that ear just kept getting worse, and he often say it felt blocked up. He'd had chronic ear infections as a kid, and one time his eardrum ruptured.
History of perforation or chronic infections, key risk factors.
The ENT doctor looked in his ear and saw a white, pearly mass behind his eardrum, like a small, growing sac. It was a cholesteatoma.
That pearly white mass is the classic visual clue.
The doctor explained it was a skin-like growth that was slowly eating away at the tiny bones in his middle ear, which was why his hearing was fading. He needed surgery to remove it before it caused more damage.
Yeah, they can be quite destructive.
Expert, that description of a white, pearly mass and the foul-smelling discharge is pretty striking. How does this abnormal growth cause conjunctive hearing loss? And why the characteristic discharge?
Mark's story really highlights the key feature as well. That growth is keratinized squamous epithelium, basically. Skin cells trapped in the middle ear space where they don't belong. It often starts in a retractor pocket, like a little divot in the eardrum, or through a hole from a past perforation. As this skin sac grows, it sheds layers of old skin and it can become infected. That's what causes the persistent, often foul-smelling discharge, the otorrhea.
And the hearing loss.
The growth is also quite destructive locally. It produces enzymes that can slowly erode the delicate middle ear bones, the ossicles, which are crucial for transmitting sound vibrations. Damaging those bones leads directly to conductive hearing loss, that feeling of blockage and fading hearing Mark experienced.
So finding that mass on examination is really the key diagnostic step.
Absolutely. Seeing that discrete white pearly plaque or retraction pocket filled with keratin debris on otoscopy is the main diagnostic clue. Often a CT scan is done as well, not so much for diagnosis, but to see how far the cholesteatoma has spread and if it's eroding important structures before surgery.
And surgery is the main treatment.
Yes, definitive treatment is surgical removal. The goal is to get rid of all the skin sac to prevent further bone destruction and potential complications like spread of infection to the inner ear or even the brain.
Right. Okay, moving on to a condition that impacts both hearing and balance. Ménière disease. This sounds quite challenging.
It certainly can be. The mechanism for Ménière disease is quite clear. Increased endolymph in inner ear, vertigo, sensorineural hearing loss, tinnitus, and ear fullness.
Increased fluid in the inner ear. We heard from a listener, Sarah, who shared a really terrifying experience. She recounted. One morning, Sarah woke up with the room spinning violently. It wasn't just dizziness. It felt like she was on a boat in a storm and she couldn't stand up without falling.
Intense vertigo. That sounds like a classic Ménière's attack.
Her right ear was ringing loudly, a low roar, and it felt strangely full, almost muffled.
Tinnitus and oral fullness. Check.
This wasn't the first time, but it was the worst. Each episode would last for hours, leaving her exhausted and disoriented. Over time, she noticed her hearing in that ear fluctuating, especially for lower sounds.
Fluctuating low-frequency hearing loss. That fits the pattern.
Her doctor finally diagnosed her with Ménière disease, explaining it was like a plumbing issue in her inner ear, where too much fluid built up, causing these terrifying attacks of vertigo and affecting her hearing.
That's actually a pretty good analogy.
That room spinning violently sounds absolutely awful. What's the connection between that fluid buildup, the endolymph, and this specific set of symptoms? The vertigo, the changing hearing, that roaring sound.
Sarah's experience is textbook Ménière disease. The core problem is believed to be an imbalance in the volume or pressure of the endolymph, that fluid inside the inner ear's membranous labyrinth. This condition, called endolymphatic hydrops, essentially means the inner ear structures are swollen or distended with too much fluid. This increased pressure affects both parts of the inner ear, the vestibular system, responsible for balance, and the cochlea, responsible for hearing. That pressure surge is what triggers those sudden, severe episodes of vertigo, often lasting minutes to hours. It also explains the fluctuating sensorineural hearing loss, which typically affects the low frequencies first, the tinnitus often described as a roar or buzz, and that sensation of ear fullness or pressure.
And people might have involuntary eye movements during an attack.
Yes, nystagmus is often seen during acute vertigo attacks. It's another sign of the vestibular system being disrupted.
So the doctor's plumbing issue analogy holds up. How do they usually manage these attacks and try to prevent future ones?
It's a useful way to think about it. Diagnosis is primarily clinical, based on that classic cluster of symptoms, and confirmed by audiometry showing that characteristic low-frequency sensorineural hearing loss. For acute attacks, medications can help manage the vertigo and nausea, things like antihistamines, anticholinergics, or sometimes benzodiazepines. For long-term management and prevention, the focus is often on lifestyle changes, particularly a low-sodium diet, to try and reduce overall fluid retention. Diuretics might also be prescribed.
If those don't work.
If lifestyle changes and medications aren't enough to control the attacks, there are more invasive options. These can range from injections of medication directly into the middle ear, like gentamicin or steroids, to various surgical procedures aimed at decompressing the endolymphatic sac or even cutting the vestibular nerve in very severe refractory cases. Vestibular rehabilitation therapy can also be helpful.
Got it. Okay, let's switch gears completely now and dive into vision, starting with hyperopia.
Right. Hyperopia or farsightedness. The mechanism is eye too short for refractive power of cornea and lens light focus behind retina, correct, with convex converging lenses.
Eye too short. We received a really touching story from a parent about their daughter, Sarah, a different Sarah, common name today. They shared. Sarah always held books really close to her face, Even as a little girl, she could see the TV across the room perfectly.
Ah, so distance vision is okay.
But when it came to homework or drawing, she'd squint and lean in close. Her first grade teacher noticed she was struggling to read the board sometimes, even though she could see her friends clearly from across the playground.
Interesting. Difficulty with near work, but maybe also some distance blur depending on the degree and her ability to accommodate.
At the eye doctor, they explained she had hyperopia, or farsightedness, because her eye was too short and the light wasn't focusing quite right. Once she got her little pink glasses with the convex lenses, her whole world of reading opened up, and she stopped getting those headaches after school.
Great outcome. The glasses made the difference.
So the parent mentioned she could see distant things okay, but struggled up close. How does an eye being too short lead to that specific vision challenge and the headaches?
That analogy of the eye being too short is a good way to conceptualize hyperopia. Technically, it means either the eyeball's axial length is shorter than average, or the cornea and lens don't have enough converging power. Either way, the result is that when light enters the eye from a distant object, it would naturally focus behind the retina if the eye does nothing.
Behind it, okay.
Now, younger people, like Sarah, have a strong ability to accommodate. That's the eye's lens changing shape to add focusing power. So she could often accommodate enough to pull the focus forward onto the retina for distant objects, making them clear. But for near objects, which require even more focusing power, her accommodation might not be enough, or it requires significant effort. That sustained effort is what leads to the blurred near vision, the eye strain, and those headaches she was getting.
That makes sense. And her little pink glasses,
Oh.
what kind of lenses are those and how do they fix the problem?
Those would be convex lenses, which are thicker in the middle and thinner at the edges. They are also called converging lenses, or plus lenses. They work by adding converging power to the eye's optical system before the light even hits the cornea and lens. This helps bend the light more strongly, effectively moving the overall focal point forward so that it lands precisely on the retina, both for distance and, crucially, for near vision, without requiring so much accommodative effort.
So it reduces the strain.
Exactly. Diagnosis is done through a comprehensive eye exam, including refraction to measure the degree of hyperopia. Besides glasses or contact lenses, refractive surgery like LASIK is also an option for adults who qualify.
Right. Now let's naturally explore the opposite condition, myopia.
Yes, myopia or nearsightedness. The mechanism here is eye too long for refractive power of cornea and lens light focused in front of retina. Correct, with concave diverging lens.
Eye too long this time. Here's a story from a clinician about a young patient, Mark. Mark used to sit at the back of the classroom and could barely read what the teacher wrote on the board.
Classic nearsightedness symptom.
But he could read his comic books perfectly fine up close. He'd always squint when he tried to look at distant signs, and watching a movie at the cinema was a blurry mess unless he was right up front.
Yep. Distance blur, clear near vision, textbook myopia.
His parents finally took him to the optometrist, who explained he had myopia, or nearsightedness, because his eyeballs were too long and light focused too soon. Getting glasses with concave lenses was a revelation. Suddenly, he could see every leaf on the trees across the street, and the world just snapped into clear focus.
That revelation moment is something many people with myopia remember vividly when they get their first correction.
So if hyperopia is the eye being too short, then myopia is the eye being too long, causing problems mainly with distant vision, is that right?
Exactly right. In myopia, the eye's axial length is generally longer than average, or the cornea and lens have too much converging power. The result is that light rays from distant objects are focused too strongly, causing them to converge at a point in front of the retina instead of directly on it.
In front this time.
Yes. By the time the light actually reaches the retina, the rays have started to diverge again, creating a blurred image for distant objects like the whiteboard, road signs, the movie screen in Mark's case. Near vision, however, is often clear because the light from close objects is naturally more divergent, and the eye's strong focusing power brings it to a sharp focus on the retina without needing correction. The squinting is an attempt to create a pinhole effect to improve distance clarity slightly.
And that revelation, with his new glasses, what type of lens corrects myopia and how does it work?
Mark's glasses would have concave lenses. These are thinner in the middle and thicker at the edges, also called diverging lenses or Meniere's lenses. They work by diverging the incoming light rays slightly before they enter the eye. This effectively weakens the overall focusing power of the eye system, pushing the focal point backward so that it lands precisely on the retina for distant objects.
So it counteracts the eye's excessive focus power.
Precisely. Like hyperopia, it's diagnosed with a comprehensive eye exam and refraction. Correction options include glasses, contact lenses, and various types of refractive surgery for adults.
Okay, fascinating. Finally, let's unpack our last condition for this deep dive, astigmatism.
Astigmatism. The mechanism here is abnormal curvature of cornea, different refractive power at different axes. Correct with cylindrical lens.
Abnormal curvature. This story, from a patient named Lisa, really captures the specific kind of distortion involved. She shared, "When Lisa looked at traffic lights at night, the lights would stretch into blurry streaks,
Ah, the streaking or ghosting of lights is very characteristic.
and street signs looked a bit warped, as if they were written in a funhouse mirror. She could read, but words on a page never looked quite as sharp as they should, and she constantly rubbed her eyes."
Yeah, blurred or distorted vision at all distances, often causing eye strain.
At her eye exam, the optometrist explained she had astigmatism. Her cornea wasn't perfectly round like a basketball, but more like a football.
That's the classic analogy.
This meant light was bending unevenly. Her new glasses, with their special cylindrical lenses, made everything sharp and clear, finally correcting the subtle distortions she'd unknowingly lived with for years.
Great. The cylindrical lens is the key.
So Lisa's description of blurry streaks and warped signs, that sounds quite different from just blurry. How does an irregularly shaped cornea, like a football instead of a basketball, lead to this specific type of distorted vision?
Lisa's description is spot on. With astigmatism, the core issue is that the cornea, the clear front surface of the eye, isn't perfectly spherical. Instead, it has an uneven curvature, steeper in one direction or meridian than the other, like the shape of a football or the back of a spoon. This means the eye has different refractive powers along different axes. So instead of focusing light neatly to a single point on the retina, like a non-astigmatic eye would,
Right.
an astigmatic eye focuses light into two separate focal lines at different distances. This causes the vision to be not just uniformly blurry, but distorted, stretched, or shadowed. Lines might appear wavy, and details can be hard to distinguish clearly at all distances, leading to that eye strain and headaches from trying to compensate.
I see. And the special cylindrical lenses in her glasses, how do they manage to correct that uneven bending of light?
Cylindrical lenses are the specific solution for astigmatism. Unlike spherical lenses used for simple myopia or hyperopia, which have the same power in all directions, cylindrical lenses have refractive power in only one specific axis. They are precisely oriented in the glasses or contact lens to counteract the uneven curvature of the patient's cornea. They add or subtract power only along the specific axis that needs correction, effectively neutralizing the cornea's uneven refraction and bringing those two separate focal lines together into a single sharp point on the retina.
Making everything sharp and clear, like Lisa experienced.
Exactly. It corrects the distortion. Astigmatism is diagnosed during a comprehensive eye exam using refraction techniques that measure the power needed at different axes. Correction options include glasses with cylindrical lenses, toric contact lenses, which are specially designed to stay oriented correctly on the eye, or refractive surgery techniques that reshape the cornea.
Wow, what an incredible journey through these conditions today. I mean, from the subtle sensory loss in tabes dorsalis and the stark reminder about vaccines with poliomyelitis, right up to the different ways our vision can be affected by the eye's shape. It's truly amazing how these very specific mechanisms lead to such distinct clinical pictures.
It really is.
And hearing the stories really makes the facts stick, doesn't it? Brings it all to life.
Absolutely. And if you think about the bigger picture, it just underscores how intricately all our body systems are connected. Understanding the underlying why the mechanism really helps make sense of the presentation, the symptoms and signs, and also points towards the right path for management for each of these pretty diverse conditions. And this kind of deep dive makes me wonder, for you listening, as you reflect on these stories and mechanisms we've discussed, what connections maybe stood out to you the most? What did you find surprising about how these, sometimes small, details can have such a broad impact on someone's life?
That's a great question. Definitely something to think about. Keep those connections in mind. We really hope this deep dive has given you a fresh perspective and some truly memorable insights into these conditions. Thanks so much for joining us on the deep dive, and we can't wait to explore more with you next time.